is cholecalciferol or calcitriol, which means they are really from what? A backbone of, those of you who knows a little bit about chemistry, backbone from cholesterol or from the chemical component of a steroid or hormone. So with that, there are two forms. We have vitamin D2, which comes from plants, and vitamin D3, which comes from animals. But if you don't see any kind of a suffix or a number, that means it's combined between vitamin D2 and vitamin D3. The most source is really sunshine. So what we are interested, oh, I'm really bogged down with not being able to point. But the biomarker of the test is called serum vitamin D, which is your 25-OHD. So when you have an article, you probably would say, what is that? That's serum hydroxyvitamin D. That's not yet active. The body cannot yet uptake that. Yeah? So my goal is to impress to you and emphasize that there is such prevalence of vitamin D deficiency. So what does that mean? Just in the recent studies, within our nation, we have about, 35% to 42% of our population are suffering from vitamin D deficiency. And according to Dr. Hollick, who is dubbed as the father of vitamin D, worldwide, we have about 1 billion people who are at risk for vitamin D deficiency. And also, a study by Dr. Adams from UCLA, he noted that even here with us, sunny California, blacks, Asians, and Latinos have about 90%, over 90% insufficiency. But blacks have the highest prevalence of vitamin D deficiency. So then now in my next slide, I want to impress you that, there you go. The next slide is telling us, worldwide, this is a map. Oh, so sorry, see, I should have just insisted on my own thing. Okay, let's see. This one. I'm trying to impress you that this map was just published recently, last May. I'm so sorry. So anyway, this map shows you, worldwide map, that there is indeed a global pandemic problem of vitamin D deficiency. So this is why I needed my pointer. If you look at the middle where it says Northern Europe, where you have the two bars, the first bar is down below, is 92% of the general population, or in the general population, 92% have prevalence of deficiency. And the pregnant ladies, the ladies up here, take a look, 70 to 100% in Northern Europe. Now, how do we fare as, again, I need a more pointer. This one doesn't point into them, but outside. But anyway, in the United States, our country, take a look. We have still 36%, a third of our population of vitamin D deficiency. But take a look at our pregnant ladies. Still about 27 to 91%. This is very current, May of 2017. But what about our sunny, down under, right? Australians. They didn't do much better neither. Take a look. They have about, 56% in the general population. And still you have 25 to 65% of pregnant ladies who are vitamin D deficient. So indeed it is a pandemic of vitamin D deficiency. Now, so what is vitamin D deficiency? So you think about it, I'm so confused with those numbers, right? But what we want to really know, see, this is why I wanted to point. In the middle is 30 nanograms per ml. It's the acceptable range that we could have from somebody. So if you take a look, going to the left side, your right side, of course, is the normal green levels. We want everybody to be between 40 to 60 nanograms per ml. But if you go below 30 to the 20, you're insufficient. Why? What does it mean, osteomalacia? Painful bones and muscles, of course. And we don't want to be osteoporotic. Yeah, most of us, by the time we're 55 or 65 and above, we suffer fragile bones. We don't want to have rickets, which is about below 20 nanograms to precisely about 12 or 10 nanograms per ml. So with that, I wanted to impress you. Why is there a lot of studies? Why do you say in the media, every now and then there's always vitamin D. There's controversy this, and there's new news and that, and so forth. Because with the, expansion of its role due to the vitamin D receptors that has been found out about 3 decades now. The role of vitamin D has really expanded, meaning to say we are no longer just doing kidneys function, meaning When it comes to through the skin, it goes to the liver, hydrolyzed or metabolized by the liver. Then it goes through kidneys. It still become the active calcitriol. With that, we uptake it to prevent us from bone fragility and calcium homeostasis. But I wanted to impress you that it is not just in the bones and in the kidneys. Take a look. It is also found in monocytes, meaning the tissues that helps us prevent infection. And lastly, down below, if you see, they are in the tissues like prostate, breast, lung, and so forth. Why? Because these ones, when they are in the cells, it prevents us. About 800 genes of having vitamin D receptor, which means it helps us in the cell regulation. We don't want overgrowth of other cells that are going to be cancerous. That's why the massive studies are on this non-kidney function of vitamin D. That's why it's now been noted that there's now an effect on prostate, breast, lung, and other tissues because of that intracellular function of vitamin D. So, now with that we are talking about cognition, I just wanted to let you see how, probably you have seen this before. See, she's nodding at the back there, thank you, ma'am. What it just tells you what the difference between the control and the one with Alzheimer's. If you could see on your left side, you see there's a lot of red things. That's the circulation, well-fed brain cells by the glucose. The basic element, energy source of our brain is glucose. But take a look on the right side, your right side. You could see that some parts of it have no red colored echo. So meaning to say, so to speak, their brain cells dead, meaning to say they are not uptaking glucose. And that's what it looks like when a patient has Alzheimer's disease. Yeah? Now, this slide is simple. It's just a bar. But I wanted to tell you the message is, this is just again very recent, and I got it from Alzheimer's Organization, Fast Facts and Figures. What it tells you that, we are not doing a good job preventing deaths from Alzheimer's disease. Take a look again on all the bars going down. They're all negative, meaning we make a difference with breast cancer, minus 1% of deaths between the year of 2000 and 2014. Even HIV, we still have about minus 54% because of the new medications. But Alzheimer's disease, between years 2000 to 2014, is going up 89%. So again, you know there's not cure, it's hard to prevent, and we are increasing because of our population is also growing older, yes? Welcome. I think maybe there's some flyers for you, but anyway, I'm Rose, Dr. Sakamoto. This is a good timing for you because we're just going to the cognition part. Anyway, not to bore you with all the studies, there are many studies out there that are showing that vitamin D is connected, associated with cognition. Cognition meaning the memory, the critical thinking, short and long-term memory, executive function, and so forth. But anyway, so it shows that low levels of vitamin D, was associated with cognitive decline according to Goodwill. And in Freud even studied French people, about 1,000 population, for 12 years. And he noted that faster rate of decline for those people who have low levels of vitamin D. Again, we have also Caracas, who said there's poorer neural skills when you have low vitamin D. Last but not the least, this is just our neighborhood in here. UC Davis, Dr. Miller, Joshua Miller, you can Google him, but anyway, very noted. Why? He followed up a multi-ethnic cohort, meaning many ethnicities and race, about 369 something. Followed up for 5 years, and guess what? 3 times faster to decline in cognition than versus those healthy subjects who had normal level, about 20 nanograms per ml of vitamin D. So with that, I wanted to show you that what can we do? Seems like, oh my God, all these studies are coming up, right? So very easy, really. If you think about it, nothing really new about this. We cannot do anything. Again, I'm not able to do it with my pointer, sorry. With the old age, we can't do anything about that. I wish, right? We're here all times, okay, how could I do robustly aging and successful aging? But the other risk factors, certainly we can make a dent or difference. Smoking, diet. Yeah, should be high, should be high in vegetables and fish, but those are really at high risk if you're having a lot of saturated fats from meat usually. Lack of exercise, obesity, and of course smoking. I know we're making a dent here in California, but as a nation we still have a lot more to do. Now, so how much vitamin D? Now this is recently published guidelines this year. So we want to impress you, I skipped that one, but it's a summary really of what we want to be targeting. So these are the new guidelines, because you say, oh my God, somebody said this, I'm overdosing myself, somebody says I'm undertaking, or so forth. So these are the new guidelines, it's published May again, as I said. If you see the neonates, even less than, that's why I love vitamin D. It's not just for when you're older, but even from less than 1 month up to death, we can take vitamin D. You don't even have to do supplements if we're good in sunbathing, but most of us don't do that because of our lifestyles, right? So neonates, we can even up to 1,000 IU, which is just really 25 micrograms, not even a milligram, 25 micrograms per day. Infants and children, up to 10 years old, is what? Up to 2,000 IU, which is again going to be 50 micrograms per day. Even children and adolescents, again it's aged 11 to 18 years age, we can do up to 4,000 IU, which is just what? 100 mics per day. Micrograms, which means 1/1000 of a milligram, yeah? And then what about adults? There you go. If you're 50 or, with this one, start off really, we say 65 and above, you could do by what? 4,000 IU up to 10,000 IU. A big difference from what before, even Institute of Medicine said only up to 4,000 IU. Studies in Boston and other, my colleagues are doing 7,000 a day. My study, which we will introduce by my students, is having supplementation of 5,000 IU, which is just what, 250 micrograms. But anyway, again, I show you, it's recently published. So with all this talk, what can we do, right? So protective, you know that you're coming in here to be intellectually stimulated. So if you have higher degree, higher education, less mental decline. And if you're well exercised, those of us, you know, by the time 55 and above, population-wise, we have a lot of people who are, what, with hypertension. Do take your medications. And then low cholesterol diet, no-brainer there. Yeah, so vegetables and fruits, nuts and berries, and protection, of course, from head trauma. So generally, general preventive, remember my part in being in love and passionate about vitamin D, because my focus of my doctoral degree is on preventive medicine, preventive care. So, good general nutrition. We need to do adequate calcium and vitamin D, if not by supplements from the sun. And how much? About 10 to 15 minutes, 3 times a week would be enough. Achieve a level of above or at 30 nanograms per ml. And of course, regular weight-bearing exercise. And we know about the smoking, right? I mean, I don't know if there's still some older people who cannot let go of that. They need some help. And fall prevention strategies, of course. I think that might be my last slide. So I bid you, this is our goal, if I could get you to participate in our vitamin D and cognition. Because the caveat of all the studies right now, they are just correlations, meaning they are association. What we need are randomized controlled trial. Our study is about a, what? Pilot study on RCT, where we have to test pre and post testing. Pre-test for the vitamin D and cognition, get them to 6 months supplementation, and then thereafter test them again. Was there a difference in their cognition? And did we bump up the vitamin D level? So I stop and I give my students in here, and I will ask you if you have your question, I'll answer them at the end of the talk. So maybe let's start with Steve and Richard. They'll introduce themselves.
Hi, good morning everyone. My name is Richard. I'm one of the volunteers working with Dr. Sakamoto.
Hey everyone, thanks for coming. I'm Steve. I'm a registered nurse. I have the pleasure of working with Dr. Sakimoto for the vitamin D study. So pretty much we're working alongside her, helping her out. We're both registered nurses, graduates at Cal State Fullerton with our Bachelor's of Science in Nursing. And right now I'm in charge of the lab portion. So if you do decide to sign up for the study, which we all encourage you to do, you can have your we draw your pre-study lab. You could have it done here, since it's probably convenient, since you guys are all members of this medical group. Or we have our home base at Cal State Fullerton, where you can have it drawn at the Student Health Center there. It's all complimentary. And if you're below 30 nanograms per cc, we put you on a vitamin D for 6 months, 5,000 units a day. And then after that's done, we draw your post-treatment labs and post-cognitive study that Michael will talk about. And Richard's going to tell you about just the intake forms and all the process that goes along with it.
So I'm just going to talk about a little about the intake form. So if you're interested in the study, which I hope you all are, we're going to send you like a pre-screening form, which like has some demographics in there, and the most important part in there is if you're taking multivitamins. So because we're targeting the below 30, which is the insufficient and deficient group. So in order to get that population, we're looking for, if you're currently taking any like vitamin D supplements, we're looking for for vitamin D, we're looking for below 1,000 units, and calcium also for below 800 units. So if you're taking like one multivitamin, it's still okay because it's usually 800 units. So once you fill out that screening form and we do like a general health history form, we're going to set up a consult meeting with Dr. Sakamoto at Cal State Fullerton. It's all Cal State Fullerton right here. If you do decide to go to Cal State Fullerton, we'll give you like parking pass. It's all complimentary. So other than that, once you get into the study, you'll get like what Steve was talking about, the pre-lab test and then the pre-cog, and then the vitamin D, and then post-cog and post-labs. So I'm going to hand it over to Michael, who is going to talk about a little bit about cognition.
Alrighty, good morning. So my name is Michael. I'm working alongside Dr. Sakamoto with the vitamin D study. I'm under the psychology department, and I'm one of the students that is running the cognitive assessments. And how the way the cognitive assessments work, it's about 20 to 25 minutes, and we're providing that service as well as here and at the campus. It's we start off with the first test, the mini mental, which assesses the global cognition. But then to better encompass your whole cognition, we have other tests as well. We have logical memory, and where we give you a story and we want you to recall all the details, and then we later ask you to give us the details on that story later at the very end of the exam. And we also provide the Stroop test, and then we also do a test of PANIS. It's a positive affect and negative affect. And all these tests combined are just testing the memory, concentration, delayed recall, recognition. And so it's a nice little way to, test your brains and all that, so we can assess the cognitive development. So again, this is going to be on the campus as well as on this site.
Thank you for that. Thank you, guys, or my students here. They are so valuable in our study. So just briefly, I want to clarify, is that you don't have to be traveling if you don't want to go to Cal State Fullerton, because of course it's crowded and parking might be a little bit challenging, even if we could give you some free ones. So we bring it to you. We only ask if we could have, of course, Tina is very good in coordinating this, Ms. Franklin. If we could 2 people, it's worth 2 of us to come in here. One would be doing the cognition testing, and of course one would be helping with the forms. And I would be, if it's the time that I have allotted, then I can come on Tuesdays or Monday or Wednesday mornings. Meaning to say we'll make it, we'll be flexible to come in here and give you that service. If you have your blood testing in here, because it's very accessible to your primary care provider. And I also, by the way, I'm also a nurse practitioner, so I also treat patients. So that's why my strength is because my background is I have been, making rounds of nursing homes way before and treating older people. But anyway, geriatric patients. So what I'm trying to say is I can come in here and talk with you and bring our services for your convenience. So all we ask is, if you are going to be with this study, we want you to be on vitamin D supplementation. That means, who among you, by the way, are already taking vitamin D? You see how you are robustly aging? So that would be good to know if you have your blood level. And now we're going to open it for questions. So if you are already on the vitamin D supplementation, which is great, you're doing that for your bone health, I can at least see where you are at, what's the purpose of you're taking that at what level, what dosage. But be aware that if you're in the study, we want to make that one up to the maximum of 800 IU. So if you're taking 2,000 or 1,000, are you willing to drop them? Because 800 IU right now, or international units, is really the cutoff of what the Institute of Medicine is prescribing out there in our population for bone health, meaning from 70 and above, it's 800. From less than 70 to about 60, 600 IU. And below that would be 400 IU. So meaning to say, well, if you're in the study, you're not bare. Meaning to say you're still covered, but for the bone. Because remember, it's going to affect our limit of the 5,000 we give you if you're going to be able to pick up the active pill. So we're going to be doing 5,000 plus your multivitamin or whatever you're taking on the side, which is about 800 IU. I see a hand in here, yes. Good question. Usually in a multivitamin, depending on the brand, you have 400, 600, 1,000. Some people, which is really what I advise, if they just come for me for their bone health, start with a separate, not in the multivitamin. Then you can control to 1,000 to 2,000, if that's really what's needed. Remember, the rule guidelines right now is this is being individualized. What's your ethnicity? What's your weight? What's your age? What's your disease condition? Because we cannot just lump up everybody, oh, 1,000 is good enough for me. Oh, my friend said it's too much, you're taking 5,000. But even then, remember, the way we absorb calcium is less when we are older patients. And how many of us are really sunbathing? And they're afraid of the dose because they said, sounds 1,000, it sounds so much. It's just considered a standardization of international units. Kind of like, do you question when you take aspirin? You have 81 milligrams. Oh, 325 milligrams. 300? How did that happen? The baby one is 81 and now you're giving me 325? No, because it's just the elements standardized in the whole world that it's milligrams. Same thing with the vitamin D, because they're minute micrograms. All over the world, it is international units. If you want to really convert, 40 IU is equivalent to 1 microgram. And that's why, for part of my saying, but it's not really a high dose, it's very minute, because I said, what is microgram? 1 over 1,000 of a milligram. Yes, ma'am. Good question. Now, if you're doing the vitamin D, oh, I'm sorry, it's supposed to be
Can you give too much
repeated.
vitamin D like you can too much vitamin A?
Very good. She is so smart. I'd like to be beside me. Anyway, think about this. From sunlight, yeah? Have you heard of somebody having overdose of vitamin D due to the sunlight? We were born as nomads evolution-wise. So we have indeed a capacity in the skin that transfers it to, believe you me, another kind of a component is cholesterol, tachysterol, and they all go through our defecation, or we get rid of it somehow, So that's why we don't do overdose. Now supplementation, yes, because if you overdose, over what? At the long term, taking 100,000, 60,000, who would be taking, you can hardly even take 5,000. Who would be taking 60,000 every day? In fact, to give you one, even in literature, and I'm not just saying this, you can look it up, it's readily available. Even a patient who's been taking 60,000 without knowing that he was already on 60,000 because he was doing the 50,000 IU that's prescribed by the primary care provider, and he had like 1,000 or so, or 10,000 that he bought over the counter, because you can buy this even through the internet. And he was taking 60,000 for 3 months. And what we do, we just say, stop it for a month, drink lots of fluid, we monitor you to see if your calcium is the one that we're trying to avoid. Because then you have propensity to do what? Calcium salts in the kidneys. We don't want that. And calcium can also irritate sometimes our heart rate. But I said, in fact, didn't you see the slide? I had that copied verbatim from the guidelines of the gurus, the endocrinologists. No one really overdosed, was just taking about 10,000. People would be overtaking 60,000, 100,000. Well, why would somebody be taking those? By mistake. But even then, it's a long term. If we have a patient who's taking 5,000, she thought it was the big twice a day. She was doing it for 1 month. She didn't have anything. I just stopped for 2 weeks and resumed. So really, it has to be, sorry, I got your hand. Really, we monitor in this study we have. That's why I'm having a lot of a challenge of getting participants. We screen too much, meaning to say you have to be 60 and above, very healthy, no cancer, no kidney problems, no recent surgeries, no history of Alzheimer's, no dementia of any sort, and you haven't had any, what you call this, bleeding of anything. No. So we pre-screen a lot. So needless to say, I only have 11 right now. It's been like 4 months we have this. Because we pre-screen so that at least for the safety for 6 months, and we're only giving 5,000 IU, which is just 250 micrograms. Yes, ma'am. Oh, yes, sir, first.
So this 5,000 dose, is that a single pill, a blue pill? How many
Good.
times a day?
I like that, sir. Yes, the question was the 5,000 a single pill, a 2 pills, a twice a day, something? No, sir. It is indeed a caplet, which is one small little, we should have brought our pill. 5,000 IU is just one tiny little caplet, and once a day. You can take it anytime with or without food, because did I tell you that just sunbathing, if a whole patient or whole individual, that's just your bathing suit, you leave it for a good 2 hours, how much do you think you're going to uptake of vitamin D? 20,000 IU. But us older people, are we sunbathing? Only the young ones sunbathe, and, in the beaches. I probably have experienced that before, but anyway. So we are not, in the medical world, we are not scared or even have an iota of hesitancy to put a patient on what you call high dose, because they're not, they're micrograms. They're just sounding big because of the international units, 1,000 things. But more than that, there has not been somebody who has had a bad effect from taking 5,000 or 10,000 a day. So we are very highly confident on that. Any other question, ma'am?
So the answer to my question is if you're taking a vitamin D supplement, your body doesn't need it, it goes out into your waste. You can't overdose on a supplement of vitamin D.
There are two parts to your question. If I get this right, so your question was, if you're taking the vitamin D supplement, and your other question was like, based on that premise, that we cannot overdose on vitamin D supplementation, what I just said is, if you're taking 60,000 IU and over every day, yes, you might have an overdose in the form of calcium salts, but very rarely, because it has to be taken long term. How is long term? 3 months, 6 months, and you didn't know you're taking 60,000 or so IU of vitamin D. In the body, I think the second part you're saying is, if it's sunlight, indeed, you do not overdose, as I said, because you're not taking it, but the sun, your skin converts it into the chemical reaction of lumesterol, tachysterol, and it is being output in our feces, so to speak, not to dampen your pre-lunch appetite. Yeah? But anyway, so did I answer your question, ma'am? If it's from sun, if you do supplementation, no one will prescribe you like a 50,000 to 60,000 daily. And even the 50,000, how many of you have had an experience? We do it weekly. How long?
Once a week.
Very good. We do it weekly. And we monitor you within a month, and then again another month. And by the way, vitamin D is so dynamic, depending on your absorption. If you're older, less absorption. Latitude where we're living, our color, and what time of the day you're out there, and what is your condition when you're taking the vitamin D, and how heavy are we, or obesity and BMI. So there's a lot of things that plays into it. In short, it is hard, so I say, it's rare to have an adverse event due to supplementation. Somebody who's going to be taking more than 10,000, you better be under somebody's care, yeah? Because it's no longer over the counter, yes? So then, therefore, it's really rare that somebody, you wouldn't have saying, oh, you overdose on vitamin D. Maybe you will say, oh, you have high calcium, you shouldn't be taking more vitamin D, because the number one role of vitamin D is to uptake calcium. That's really, but all the benefits we have, that's why it doesn't affect on the 30 nanograms. We want people to be between 40 nanograms to 60 nanograms because of the non-skeletal benefits. That's really the message I have here today. If nothing at all you've forgotten from my slides, it's the level that the more we go into the 40 nanograms to 60 nanograms, the better off you are on the non-skeletal benefits. Why do you think Institute of Medicine as of 2011, when they reviewed the dietary intake recommendations for all the world we have, in our country first, and then Canada always uses our data, is that what? They said it's enough to just do 800 IU, as I said, for bone prevention. But now when we're getting just that, Why not take it at a dose that prevents you from other things? I just showed you. It's all now accepted, and there's a lot. I mean, you go by thousands of studies are doing on the cancer prevention, are doing on. Why do you think they are now saying even studies like kids who are put on vitamin D supplementation during the winter, they come back by spring, they don't have a lot of colds and stuff. This is a study in Japan, yes.
So what you're saying is that you're going to conduct a 6-month study, 6 months?
Yes, sir.
We're going to do a cognitive test on the front end, a cognitive test on the back end.
Well said.
And you're going to see differences between cognition between the 6 months and 6 months?
Yes, sir. That's it. I to repeat this question or a little comment, clarification. Our study, I beg you to participate if you can, and we want people, as Richard was saying, we need people who are tending to be at the low side, because we have already a lot of controls who are like robustly aging. They've been taking 5,000 on their own and 4,000 over there. So if you're willing to come down to about 800 and then show me your latest if you have about a month or two of your blood level, and then I can say you can join. And then first we do a pre-testing to answer, to clarify again and repeat, because it's a lot to remember. We first test you where your blood level of vitamin D to make sure that you have indeed a low level. We just don't give you the supplementation, but you don't need the supplementation. Yeah, no brainer there. So, meaning to say, first we test you where your blood level. But if you come to me, Dr. Sakamoto, my latest one a month ago was only 15 or only 23. What can I do? How much are you taking? If you're over 2,000, you know already that you are low level, but are you willing to drop down from your 2,000 to 800 while you're with us? And you say, oh, wow, that's bare. Because 800 is enough for the skeletal bones, remember? So then you say, oh yeah, I'm willing. Most of my students, my patients or participants are doing that. So okay, so you come to us, we pre-test you for your cognition, and of course the pre-testing for the blood level, unless we use your recent one. Why poke you again if you have had within a month or two of blood level? Then we put you on a supplementation. Here's the good thing to remember. When you do this, you don't even know whether you're getting the active 5,000 or the placebo, because it's the strength of my, when we, the three of us, we wanted to make sure this is really a randomized controlled trial. How effective are we if everybody's just taking it? So we said, what about the people who are not taking it? Yeah? So by the end of 6 months, we test everybody again. Was there a difference? Whether you took the placebo or you took the active 5,000 IU, was there a difference in your memory? Was there a difference in your blood level? Yeah? So that's the beauty of it. So if I could have at least 15 people, from the Cadicious group, we'll be ready to launch a full, as we designed this before. So any other question? That was a great comment or confirmation.
Is there any age level that you stop at?
I like that. So you're so good. From 60 years and above, no stop. Oh, I take that back. 90 years old. Yeah. Because I think my flyer. I brought some flyers in here that are just, if you see my folder, my blue one, you can give them that one. But anyway, so that's that. Yes, ladies, and you don't have to be really, in fact, my goal is the healthier you are. This is my intention is, can we make our older adults, or our older from, if I would have the choice 55 and above, stay robust or active or, not be ailing. Because it's too hard on everyone if you're already fragile or in and out of hospitals or in and out of nursing home. So, so that's a good question, sir. Yes. I think I put it in the 90, yeah? 92, 90? Yeah. So, any other question? Yes, ma'am.
Are you talking about particular vitamin D here, or like B12, B3, or?
Oh, I like that. See how informed she is. I could tell she's real, right up top with the information. Her question was, are you talking about a particular vitamin? And I'm sure because she came a little bit, 5 minutes or so late. The first slide was there indeed two forms. D2 is from the plant world, and D3 is for the animal. And for humans, more effective to absorb is the D3. So this one we are giving is D3, which is your calcitriol. And this is what we give, or calcitriol, cholecalciferol. This is what we give to the participants because it has been evidence-based, well-studied, that D3 is much more effective in raising up your vitamin D level. The picture is, if nothing at all, you don't have to really join us, but I would like to really be strongly convinced that you need to be at least at 30 nanograms and above. And how you reach this is upon sunshine and plus supplementation. Now we're going into winter. We're all bundled and we're all staying, cold. In fact, it is again a well-noted fact. All our vitamin dips down, even in sunny Australia, even in sunny California and Florida. Anyway, so again, it's seasonal variations. In fact, I'm trying to publish right now, if I just have time again, on seasonal variations of vitamin D, how it affects older adults in vitamin D status. Anyway, that was a good question. I answered you, ma'am, miss? Yeah. You're too young to be ma'am. Yeah.
I have a question.
Sure.
Because I'm just on the border with vitamin D. What would be for me, and we are too young to participate. So what vitamin D I should take? Other of my blood tests are perfect, right? Everything, but I was really surprised because it's the first time that I hit low, but it's just borderline. Not too low, but just borderline.
You're even lucky. Thank you for sharing that, miss. This is not unusual. It's very common. Even my professor said, you mean I've been hiking all this time? These are preventive medicine residents and other colleagues I have. You mean I'm still low? And I'm, guys, what? Because he's Asian, the one that I'm referring to. And other people who have tend may be yellow, brown, because why? We have melanin, right? It really deflects the UVB, which is about 290 to 312 nanomole. Anyway, so with that, to answer your question, depending how low you are, because she said her question, if you haven't heard much, did you hear at the back? She said she's just borderline. How would what if I'm not in the study because she's too young? So how much do you think is a good way to improve her vitamin D level? As I said with that, usually right now, depending on how low, like you should say 30 nanograms in really our acceptable range, say you're only 27 or 26, which happened to me, then you just do a 2,000, and after 3 months, you have a blood test, check if it's still low, then bump up to 4,000. 4,000 to 5,000 a day is very, very good for everyone. Yeah. So then, very good. The next question, she said, which vitamin D? Remember I said D3 is the best one. Don't bypass D2 at this time. It's been kind of 15 years we transferred to D2. The only reason we do D2 at the 50,000 IU, at that time this was manufactured, there was no D3 at the higher level. And this is why we've been giving 50,000 IU on outpatients. Yeah? That was a good question. Yes. Anything more? Did I take up much of your time? Yeah, it's your time. I'm right here, so you still have about 5 minutes. We're supposed to be here from 11 till 12. Any other things? Say so, or any other question? Sure. That's what we're here for. In fact, I offered to Dr. De Nicola, one of the practitioners, and she's not, she must know.
Our medical director.
Yeah, our medical director, yeah. So, that if we have people in here, that would have been a good time to sit down and we can stay with you like half an hour or so and talk more. And then if you're ready, either give us